Welcome to the Core Therapeutic Module on Cardiac Arrhythmias and Advanced Cardiac Life Support. I am Dr. Heather Draper, Clinical Pharmacy Specialist in Emergency Medicine at Mercy Health St. Mary's in Grand Rapids, Michigan. This presentation is part of the ASHP Core Therapeutic Module Series, which is designed for pharmacists seeking to update their knowledge and skills commensurate with board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you to consider how you would answer the question. You may wish to write your answer and the correct response in your handout. To get started, I have nothing to disclose related to the content of this presentation. The learning objectives for this presentation are to interpret the signs, symptoms, and diagnostic tests for cardiac arrhythmias, to identify drug-related problems, including drug interactions and adverse effects associated with pharmacotherapy of cardiac arrhythmias, to identify and prevent drug-induced cardiac arrhythmias, to determine the most appropriate therapy and monitoring for cardiac arrhythmias based on patient-specific information and the most current guidelines, and finally, to utilize advanced cardiac life support or ACLS guided therapies. To begin the presentation today, we are going to discuss rate control versus rhythm control in patients with atrial fibrillation. Our first patient is CR. CR is a 78-year-old male patient who was admitted to the hospital for intermittent shortness of breath and palpitations, which have been present for approximately 1 week. An initial ECG obtained in the emergency department revealed atrial fibrillation. The initial assessment reveals the following information. The patient's blood pressure is 158/94 millimeters of mercury. The patient's heart rate is irregular at 78 to 88 beats per minute. The patient's respiratory rate is 20 beats per minute. The physical examination reveals an irregular rhythm consistent with atrial fibrillation. The patient's lungs are clear to auscultation, and otherwise the physical examination is within normal limits. And then finally, the ECG reveals atrial fibrillation with a rate between 80 and 86 beats per minute. The patient's past medical history is significant for coronary artery disease, a myocardial infarction in 2009, hyperlipidemia, hypertension, and paroxysmal atrial fibrillation. The patient's current home medication regimen consists of lisinopril 10 milligrams daily, simvastatin 10 milligrams daily, clopidogrel 75 milligrams daily, and aspirin 81 milligrams daily. The first question is, which of the following treatment recommendations for management of atrial fibrillation would be most appropriate for this patient at this time? Option A, attempt direct current cardioversion. Option B, begin metoprolol succinate 50 milligrams PO daily. Option C, begin diltiazem extended release 180 milligrams daily. Or D, begin amiodarone 200 milligrams daily. I'll give you a few moments to think about this and select your answer. Okay, let's talk about this patient. First of all, the clinical presentation of atrial fibrillation varies greatly. Patients may be completely asymptomatic and have an incidental finding on ECG, all the way to patients that are unresponsive. What's interesting to note is in looking at studies going out 30 days where patients are monitored with a Holter monitor, up to 90% of patients with paroxysmal atrial fibrillation have no awareness of when they are in sinus rhythm versus when they are in atrial fibrillation. Now, that clinical presentation is dependent upon several factors. First of all, the duration of atrial fibrillation. For example, patients that have chronic atrial fibrillation and are in atrial fibrillation every day are much less likely to have symptoms than a patient with new onset atrial fibrillation. The next factor is the ventricular response. In patients with atrial fibrillation, the ventricular response is dependent on the AV node to act as a filter, and that response may be slow, fast, or normal. Patients that have a fast or rapid ventricular response are much more likely to be symptomatic than patients with a normal ventricular response or a normal heart rate. The clinical presentation will also be dependent upon the functional status of the patient. So, for example, those patients that are independent living and have a higher functional status, they're more likely to be symptomatic from their atrial fibrillation than someone of low functional status. And then finally, the clinical presentation will be dependent on the resultant hemodynamic and thromboembolic variables. So for example, patients with rapid ventricular response are frequently hypotensive. Those patients are much more likely to experience symptoms than patients with normal blood pressure. And then finally, thromboembolic complications, patients that are having a stroke associated with atrial fibrillation are likely to present to the emergency department with those symptoms. Now, overall, we can break down the clinical presentation into objective and subjective findings. Objectively, on the ECG, we see an irregular rhythm. This can also be felt when checking the patient's pulse. Patients are frequently tachypnic, and this is frequently dependent on the heart rate as well. And as discussed, the heart rate will be variable. So if you look at the EKG monitor, the heart rate being counted will fluctuate quite regularly if looking at the monitor. Patients may present with altered mental status. Again, this is most likely going to be dependent on the patient's blood pressure response and the thromboembolic variables. We may see hemodynamic instability, and then finally some of the more severe consequences of atrial fibrillation are that we can see heart failure, either new onset heart failure or decompensation of patients with chronic heart failure, and stroke. Subjectively, patients may complain of shortness of breath, fatigue, weakness. They frequently complain of palpitations when they are symptomatic. Patients may complain of being dizzy. They may have syncope or pre-syncope. And finally, the patients may complain of confusion, or their family members may note that they have been more confused than normal. For treatment considerations in atrial fibrillation, there are essentially three things that must be considered: rate control, rhythm control, and prevention of stroke. The goal for this is to control the disease, to prevent the complications that occur from atrial fibrillation, and to improve the patient's quality of life. These can be achieved both using pharmacologic therapy and non-pharmacologic therapy. In terms of deciding which treatment to administer a patient with atrial fibrillation, it's important to give consideration to patient-specific factors. These factors include things such as the type and duration of atrial fibrillation. Different consideration is going to be given to a patient with paroxysmal atrial fibrillation than someone with permanent atrial fibrillation, as well as someone with new onset versus chronic atrial fibrillation. Consideration is always given to the severity and type of symptoms that the patient reports. So patients with more severe disease requiring frequent hospitalization, for example, related to rapid ventricular response, are going to be treated differently than patients that are completely asymptomatic. The patient age comes into consideration, particularly when selecting which drug therapy to give. And comorbid disease states can help us to decide which drugs may be preferred when more than one treatment option would be appropriate for the patient. And then finally, we have to determine what our overall treatment goals are for the patient and what the treatment goals are that the patient has for themselves and what therapeutic options are available to achieve those goals. Overall, we must weigh the individual risks and benefits for each drug therapy and each treatment goal for the individual patient. The first consideration for patients with atrial fibrillation is rate control versus rhythm control. Rate control simply focuses on controlling the ventricular rate with no regard to the underlying rhythm. So essentially we're saying that we accept that the patient is in atrial fibrillation and the patient will stay in atrial fibrillation, and that's a treatment goal. The other goal being we will just focus on controlling the ventricular rate or preventing rapid ventricular response for the patient. The other option would be rhythm control. And here in rhythm control, we're going to use efforts, whether pharmacologic or non-pharmacologic, to restore and maintain sinus rhythm. So in the rhythm control strategy, we are not accepting that the patient is in atrial fibrillation. Both strategies, both rate control and rhythm control, are acceptable treatment options. So how do we decide which option we will give to our patients? Well, historically, the focus was always on rhythm control. We know that atrial fibrillation is associated with increased morbidity and mortality, and so every effort was made to achieve normal sinus rhythm. A very important paper was published called the AFFIRM trial. And the AFFIRM trial compared rate control to rhythm control in patients with atrial fibrillation. The expectation was that the patients in the rhythm control arm would have lower morbidity and lower mortality because they would be maintained in sinus rhythm compared to their comparator group, which was simply rate control. However, this study found there was no mortality benefit with rhythm control. The rate of stroke was also similar for those patients that were in the rhythm control strategy compared to rate control strategy, and the rate of hospitalization was actually higher in the rhythm control group. This is thought that the adverse effects associated with achieving rhythm control, which was done using antiarrhythmic drugs, outweighed any benefit there was associated with maintaining those patients in sinus rhythm. Therefore, either strategy is appropriate, rate control or rhythm control. Both are appropriate. So how do we just decide then which we will use? Well, there are certain patient-specific variables that would allow us to say we would favor rate control over rhythm control, understanding that there are increased morbidity and mortality associated with being in atrial fibrillation, but that achieving sinus rhythm using a rhythm control strategy really does not confer any benefit at this point in time. So those patients that may favor a rate control strategy, those are patients with persistent or permanent atrial fibrillation. So these patients are in the chronic atrial fibrillation category. Those patients that are asymptomatic or report very few or very mild symptoms associated with their atrial fibrillation. These may be those patients, again, that don't know when they are in atrial fibrillation or when they are in sinus rhythm unless an EKG is obtained. Those patients greater than 65 years of age would be in the rate control strategy group, patients with hypertension, patients that have failed a rhythm control strategy, so they have failed therapy with an antiarrhythmic drug, and finally, patient preference. What patient characteristics then would favor rhythm control? Those patients with the first or initial episode of atrial fibrillation, particularly those that are severely symptomatic at onset. Also, those patients with frequent hospitalizations. Many times we'll see hospitalizations related to rapid ventricular response and that require IV therapy for control. These patients may also favor rhythm control. Patients that have failed on rate control may also choose the rhythm control strategy. Patients less than 65, those patients with no history of hypertension, and then finally patient preference. As you can see, we have to evaluate the patient-specific factors to determine whether rate control or rhythm control will be the preferred strategy. So if we go back to our patient case, which of the following treatment recommendations for the management of atrial fibrillation would be most appropriate at this time? I believe the correct answer is B, begin metoprolol succinate 50 milligrams by mouth once daily. If we look at this patient's information, the patient is greater than 65 years old. The patient in this case was 78 years old. The patient has a history of coronary artery disease, myocardial infarction, hyperlipidemia, hypertension, and paroxysmal atrial fibrillation. If we look at the patient's complaint today, his symptoms were somewhat minimal. And the patient currently takes lisinopril, simvastatin, clopidogrel, and aspirin. Direct current cardioversion would not be appropriate in this case because the patient is stable. The patient is hemodynamically stable, has a normal blood pressure, and essentially a normal heart rate. Direct current cardioversion, which we will further discuss, really should be reserved for those patients that are hemodynamically unstable that fall into the emergency treatment category. The other treatment options were metoprolol, diltiazem, and amiodarone. While amiodarone does offer some rate control in atrial fibrillation, it is typically reserved for use as a rhythm control strategy. At this point, it doesn't appear that the patient would benefit from a rhythm control strategy. That leaves us with the two remaining options, metoprolol and diltiazem. Both medications would be appropriate for rate control in atrial fibrillation. However, we see that this patient has a history of coronary artery disease and myocardial infarction. that is a compelling indication for the patient to be on a beta blocker, and therefore metoprolol would be the most appropriate option for this patient. In terms of monitoring parameters for this patient, I typically recommend to break the monitoring parameters down into safety and efficacy. So for safety, we would want to monitor the patient's blood pressure, being that he is starting on a new medication, metoprolol, which will lower his blood pressure. We want to monitor his heart rate and ensure that he doesn't experience bradycardia associated with the medication. We would monitor an ECG looking for heart blocks and other adverse reactions associated with the metoprolol, and then finally any other adverse reactions or events that the patient may report when starting on this new medication. In terms of efficacy, we would want to monitor for symptom control associated with atrial fibrillation. So how does the patient report his palpitations, shortness of breath, dizziness, and weakness? We would want to monitor the patient's heart rate. In general, the target heart rate is less than 80 beats per minute. However, it is appropriate in some patients to achieve a more lenient heart rate target of less than 110 beats per minute. And then finally, we would want to monitor for any hospitalizations that are required in this patient as a direct result of atrial fibrillation. Let's discuss the last treatment consideration for patients with atrial fibrillation, and that is stroke prevention and anticoagulation. This patient, BW, is a 78-year-old female who was admitted to the hospital for a stroke. During this hospitalization, the patient was diagnosed with non-valvular atrial fibrillation. Other than residual effects of the stroke, the patient has had no symptom complaints related to the atrial fibrillation. Specifically, the patient denies palpitations and shortness of breath. A review of the patient's medical record reveals that her blood pressure, heart rate, and electrocardiogram have all been consistent. We see that the patient's blood pressure has been running in the range of 146/94 millimeters of mercury. The patient's heart rate has been 88 beats per minute and irregular in atrial fibrillation. The patient's respiratory rate is 18 breaths per minute. Temperature was 97.8 degrees Fahrenheit, and her ECG reveals, again, atrial fibrillation. The patient's past medical history is significant for the stroke, or CVA, atrial fibrillation, hypertension, urinary incontinence, and chronic kidney disease stage 4 with an estimated creatinine clearance of approximately 18 mLs per minute. The patient's medication administration record reveals that she is currently taking aspirin 325 milligrams every morning. She takes oxybutynin XR 15 milligrams daily and metoprolol succinate 50 milligrams daily. You have been asked to speak with the patient regarding anticoagulation options for stroke prevention and atrial fibrillation. The patient states that she has only been on aspirin in the past, and if at all possible, she would like to take a once-daily medication because the rest of her medications are once daily, and it would be much easier for her to remember. The question for this patient is, what is the most appropriate treatment strategy for stroke prevention in this patient with atrial fibrillation? A, continue the aspirin 325 milligrams daily. B, begin warfarin 5 milligrams daily. C, begin dabigatran 150 milligrams twice daily. And D, begin rivaroxaban 20 milligrams daily. I'll give you a few moments to consider your answer. Atrial fibrillation is an independent risk factor for stroke. It increases the risk of stroke about 5-fold. If we look at the annual risk of ischemic stroke, it's approximately 5 to 6% per year, not per lifetime, per year. If we combine diagnosed and undiagnosed strokes plus transient ischemic attack, this number is greater than 7% per year. And there are several pieces of literature that indicate this number is probably much higher than this. The risk for stroke remains in those patients even when they are asymptomatic with atrial fibrillation, and even in those patients with paroxysmal atrial fibrillation, or those patients that are in and out of atrial fibrillation. The pathophysiology of stroke and atrial fibrillation is quite complex. First of all, blood stagnation occurs in left atrium and the left atrial appendage as a result of the ineffective contraction that occurs because the atrial are fibrillating. This blood stagnation then leads to thrombus formation that is frequently seen on echocardiogram at that left atrial appendage. We now know from more recent research that atrial fibrillation is also associated with an increase in several prothrombotic markers, making atrial fibrillation essentially a hypercoagulable state. And then finally, numerous structural changes occur in the atria during the period of fibrillation, and this results in endothelial and endocardial damage. All three of these factors leading to an increased risk for thromboembolic complications. When looking at patients with atrial fibrillation, we can assign a risk score. This risk score that is recommended by the most current treatment guidelines is the CHADS-2 VAS score. If you are familiar with the previous guidelines, you may be familiar with the CHADS-2 score, which has been used in previous treatment guidelines. The most recent guidelines now recommend the CHADS-2 VAS score as it is a more complete assessment of a patient's risk for stroke in atrial fibrillation. A risk score is assigned to each of the following risk categories, as you see listed here. Congestive heart failure would receive 1 point, hypertension receives 1 point, age 75 years or greater receives 2 points, a history of diabetes receives 1 point, a previous history of stroke, TIA, or thromboembolic event receives 2 points, a history of vascular disease, which includes myocardial infarction, would receive 1 point, patients in the age of 65 to 74 years receives 1 point, and finally the last is female gender, which is abbreviated as the sex category in the VASC part of the abbreviation, receives 1 point. What you would do is that you would assess each patient and their individual risk factors to determine what their risk score is. What we see is as the CHADS-2 VASC score risk factors increase, the rate of stroke increases. So you can see that a patient with a CHADS-2 VASC score of 1 has an annual anticipated stroke rate of 1.3%. As the score increases to 6, for example, then the rate of stroke is 9.8%, and as the score increases to 9, 15.2% risk of stroke per year. If we look at our particular patient, our patient has a history of hypertension, is greater than 75 years of age, has a prior history of stroke, and is a female. So our patient would receive a risk score of 6. After calculating the patient's risk score, we can then come up with a recommendation for anticoagulation. The current recommendations are that patients with a CHADS-2 VAS score of 0 receive no therapy. Patients with a CHADS-2 VAS score of 1 may receive oral anticoagulation, aspirin, or no therapy. This is again going to be based on individual patient characteristics. The remaining patients, so either those patients with a score of 2 or higher, or patients with a prior history of stroke or TIA, should all receive oral anticoagulation. When oral anticoagulation is recommended, we have many different treatment options. Over the last several years, as I'm sure you're aware, many new treatment options have come to the market that can be used to prevent stroke in patients with atrial fibrillation. These options include warfarin, dabigatran, rivaroxaban, apixaban, and edoxaban. If we look at the efficacy of the anticoagulants in atrial fibrillation, we can see that each of the new anticoagulants were compared to warfarin and were essentially found to either be superior, as was the case for dabigatran and apixaban, or non-inferior, as was the case for rivaroxaban and edoxaban for ischemic stroke prevention. I do want to point out that the apixaban major trial, which was Aristotle, evaluated the combined endpoint of both ischemic and hemorrhagic stroke, and it found that it was it was not superior for ischemic stroke, but it was superior for the combined endpoint of ischemic and hemorrhagic stroke prevention. If we look at a safety comparison of the novel oral anticoagulants to warfarin, we see that in general there is a lower rate of bleeding when we look at combined endpoints of major and minor bleeding, including intracranial hemorrhage. but dabigatran, rivaroxaban, and edoxaban were all associated with an increased risk of gastrointestinal bleeding. So how are we going to select which of these anticoagulants to use in our patients with atrial fibrillation? Well, again, similar as we discussed to the first patient, the selection of an anticoagulant is going to be based on patient-specific factors. So some of these patient-specific factors to consider include comorbid conditions. As we will discuss, comorbid conditions are going to heavily weigh in on our selection for an appropriate anticoagulant. We should consider patient preference. Some patients have experience either through themselves, through family members, or through friends with anticoagulants, and they do have an opinion about what they would prefer. We should consider previous experience as well. So if our patients have previously been on warfarin, for example, what was this experience, either positive or negative? We must consider drug interactions, as this can definitely weigh into selecting the most safe option for our patients with that need an anticoagulant. And then finally, cost. We see that for patients with prescription benefit plans, often the formulary is limited to maybe only a few of these anticoagulants, and that would obviously limit our selection as well. If we look at the impact of comorbid conditions on our selection of anticoagulants, we can see that there really is not a lot of data for some of the comorbid conditions that we may need to consider. For example, currently warfarin is the only anticoagulant that should be used in patients with mechanical valves. For patients with obesity, and also for those patients with low body weight, there isn't a lot of data on how to adjust or how to address this with the novel oral anticoagulants. Currently, warfarin is the only anticoagulant that can be used concomitantly in patients with peripheral artery disease. And for liver disease, warfarin and dabigatran should be considered over the other anticoagulants. Now, renal disease is something that we didn't really consider previously when warfarin was the only anticoagulant for stroke prevention and atrial fibrillation, but now is something that we must consider. Patients with renal disease should receive dose adjustments for all of the new novel oral anticoagulants, so dabigatran, rivaroxaban, apixaban, and edoxaban, whereas previously with warfarin, this is not a consideration. And then finally, in hemodialysis patients, the only two treatment options that are safe are warfarin and apixaban. If we look at the dose adjustments that are required in those patients with renal insufficiency, we see that it is based on the patient's estimated creatinine clearance. So for dabigatran, the typical dose is 150 milligrams twice daily. For patients with a creatinine clearance of 30 to 50, plus a drug interaction, so drug interaction specifically being either ketoconazole or dronedarone, this dose should be decreased by half, as well as a decrease in half the dose in patients with a creatinine clearance of 15 to 30. And then finally, patients with a creatinine clearance of less than 15 or on dialysis, dabigatran should not be used. For rivaroxaban, the typical dose is 20 milligrams once daily. This should be dose adjusted in patients with a creatinine clearance of 15 to 50. And again, in a patients with a creatinine clearance less than 50, it should not be used. For apixaban, the typical dose is 5 milligrams twice daily. This should be adjusted to half dose, 2.5 milligrams daily, if the patient has two or more of the following factors: greater than 80 years of age, low body weight, or serum creatinine greater than 1.5, or on those patients on hemodialysis, the dose is adjusted to 2.5 milligrams twice daily. And then finally, with edoxaban, the typical dose is 60 milligrams once daily. Interestingly enough, it should be avoided in patients with normal renal function, so patients with a creatinine clearance greater than 95 mLs per minute. It should be dose adjusted in patients with a creatinine clearance of 15 to 50 to 30 milligrams once daily, and similar to all of the other novel oral anticoagulants with the exception of apixaban, edoxaban should also be avoided in patients with a creatinine clearance of less than 15. Let's go back to our patient case. What is the most appropriate treatment strategy for stroke prevention in this patient with atrial fibrillation? Well, for this patient, I believe the most appropriate option would be to begin warfarin. We determined based on the patient's risk stratification score, that CHADS-2 VAS score, that she did need oral anticoagulation for stroke prevention. So aspirin will no longer be sufficient stroke prevention in this patient. The patient discussed that she would really prefer to be on a medication that is once daily. This essentially then would rule out dabigatran because this is a twice daily medication. Rivaroxaban is a once daily medication. However, it should not be used in patients with a creatinine clearance less than 15 milliliters per minute and must be dose adjusted in those patients with a creatinine clearance of 15 to 50. We said that this patient had CKD stage 4 disease with an estimated creatinine clearance of 18 milliliters per minute. Now we would assume that the patient's renal function will continue to decline, and it's right at that borderline of when rivaroxaban should be avoided. Since it's most likely the patient's renal function will continue to decline, warfarin would be the safest treatment option in this patient. Let's move on to discuss treatment considerations for acute management of atrial fibrillation, and that is atrial fibrillation with a rapid ventricular response. During bedside rounds, you enter the room of patient BW, a 67-year-old patient who is currently admitted to the hospital for treatment of pneumonia. Upon entering the room, the team observes that the patient is breathing rapidly, is diaphoretic, and appears in acute distress. Upon questioning, the patient reports increased shortness of breath and chest pain, which began approximately 30 minutes ago. A rapid assessment reveals the following. The patient's blood pressure is 136/76, the heart rate is 148 beats per minute, and the patient's respiratory rate is 28 beats per minute. Bedside telemetry reveals atrial fibrillation with a ventricular rate of 148 to 160 beats per minute. The patient's past medical history is significant for chronic obstructive pulmonary disease and hypertension. The patient has no history of atrial fibrillation. Which of the following treatment options is most appropriate for this patient at this time? A, attempt direct current cardioversion. B, administer metoprolol tartrate 50 milligrams PO times 1 dose. C, administer digoxin 0.25 milligrams IV times 1 dose. Or D, administer diltiazem 15 milligrams IV times 1 dose. I'll give you a few moments to think about the answer. The ventricular response to atrial fibrillation is dependent on the AV node to act as a filter. When we have inadequacy of the filter, we can see a rapid ventricular response. This occurs because the atria are fibrillating, and the atria can fibrillate at a very rapid rate, 300 to 600 times per minute. If the AV node is not filtering out the noise from the atrium, we can see that the ventricular response is rapid. This rapid ventricular response is associated with a decrease in cardiac output and the potential for hemodynamic instability. And this hemodynamic instability can be severe. The clinical presentation for these patients can again be broken down into objective and subjective findings. For patients with a rapid ventricular response, we may see altered mental status, syncope, tachycardia, hemodynamic instability, particularly hypotension, ischemic EKG changes, cardiomyopathy, and acute heart failure. Patients complain subjectively of chest pain or chest pressure, shortness of breath or difficulty breathing, fatigue, palpitations, and frequently the patients will describe this as a butterfly feeling in their chest. They may have mental status changes, and if severe enough, the patient may have loss of consciousness. The treatment goals for rapid ventricular response are broken down into 3 areas. The first is to prevent the hemodynamic instability and clinical deterioration that is associated with an uncontrolled rate. For many of these patients, this severe tachycardia will deteriorate and can deteriorate rapidly. The second focus is to improve the patient's symptoms, so their subjective findings. And then the third focus is to avoid the cardiac remodeling that is associated with tachycardia, particularly in the setting of prolonged tachycardia. In terms of deciding what treatment consideration to give to the patient in atrial fibrillation with a rapid ventricular response, we have to ask ourselves 2 questions. One, is the patient symptomatic? And two, is the patient hemodynamically stable? If the patient is not symptomatic and is hemodynamically stable, then we have time to consider AV nodal blocking agents by the oral route. In this case, it's not as emergent to obtain control of the ventricular rate. If the patient is symptomatic and is hemodynamically stable, then we should consider AV nodal blocking agents by the intravenous route. And then finally, if the patient is symptomatic but is not hemodynamically stable, this is a medical emergency, and those patients should receive direct current cardioversion. In terms of the intravenous treatment options for rapid ventricular rate control, there are several available. Amiodarone is a treatment option, typically given 150 milligrams IV, followed by a continuous infusion of 0.5 to 1 milligram per minute. Amiodarone is generally preferred in those patients with acute heart failure. The next options are calcium channel blockers, diltiazem and verapamil. We do need to consider that these can lower the blood pressure, particularly in those patients that have a soft blood pressure or have a blood pressure that is trending down already that's associated with a rapid ventricular response. And then also we should use these with extreme caution, if at all, in those patients with heart failure. And then the last treatment option would be the beta blockers, esmolol and metoprolol. These, again, can also lower the blood pressure, so we have to be cautious with using these in patients with those trending low or already low blood pressures. And then, of course, caution, again, in patients with heart failure and those patients with reactive airway disease, particularly if they're currently wheezing. If we go back to this patient then, which of the following is the most appropriate treatment recommendation for the patient at this time? The most appropriate treatment option would be to administer diltiazem 15 milligrams IV times 1 dose. Now this patient is symptomatic, but patient is hemodynamically stable. Therefore, at this time, the patient does not require direct current cardioversion. It would be possible to use direct current cardioversion, but what we must consider is using direct current cardioversion in patients with atrial fibrillation increases their risk for stroke. So we would not use direct current cardioversion unless we are sure that we have mitigated the patient's risk for stroke or the patient is hemodynamically unstable and requires emergency intervention. Now, because the patient is symptomatic and is hemodynamically stable, we need to use the intravenous treatment route. Therefore, B, giving metoprolol by mouth, would not be the preferred therapy. And then finally, with option C, digoxin is not recommended IV for acute rate control. This is due to its delayed onset of action and the toxicity associated with giving digoxin intravenously. Therefore, the preferred treatment option for this patient who has symptomatic atrial fibrillation with a rapid ventricular response but is hemodynamically stable would be to administer diltiazem 15 milligrams IV times 1 dose. This dose could be repeated if needed. The initial dose for diltiazem IV is 0.25 milligrams per kilogram. This can be followed by 0.35 milligrams per kilogram IV, and that can be followed by a continuous infusion of 5 to 15 milligrams per hour as needed. Let's move on to the next patient case and talk about antiarrhythmic drug interactions. KD is a 68-year-old male patient who presents to the ambulatory care clinic for his annual physical examination. The physician indicates that the patient will require at least a 30% reduction in his LDL cholesterol and that she would like to start the patient on a statin. The patient's current medication regimen consists of amiodarone 400 milligrams daily, aspirin 81 milligrams daily, metoprolol succinate 50 milligrams daily, metoprolol 500 milligrams twice daily. The patient's insurance formulary includes simvastatin and atorvastatin on the preferred drug list. Which of the following is the most appropriate treatment recommendation for the patient at this time? A, start simvastatin 20 milligrams daily. B, start simvastatin 40 milligrams daily. C, start atorvastatin 10 milligrams daily. Or D, start atorvastatin 80 milligrams daily. I'll give you a few moments to consider your answer. This patient is on amiodarone, one of the most common antiarrhythmic drugs that are used. We know that the antiarrhythmic drugs are associated with extensive and significant drug interactions. This is especially significant with other cardiac medications. And as you well know, patients that are on antiarrhythmic drugs, for the most part, are also taking other cardiac medications. Now, why we care about this is that these drug interactions may result in clinically significant outcomes. Now, the drug interactions that we see with the antiarrhythmic drugs are primarily a result of the cytochrome P450 isoenzyme system. If we look at the antiarrhythmic drugs, we see that they use the cytochrome P450 system both as a substrate and then also as an inhibitor. The major pathways that are affected are 1A2, 2C9, 2D6, and 3A4. And as you see, for the most part, almost all of the antiarrhythmic drugs affect the cytochrome P450 pathway. There are very few exceptions to this rule when it comes to the antiarrhythmic drugs. In addition to the cytochrome P450 pathway, the antiarrhythmic drug interactions can result from an interaction through P-glycoprotein, through the renal cation transport system, and through pharmacodynamic interactions. So, for example, additive beta blockade in those patients that are already on beta blockers. If we look at some of the examples of the cardiovascular drug interactions, again, these interactions are significant. I want to point out, for example, with amiodarone, that it has drug interactions with almost all of the anticoagulants that would be used in our patients with atrial fibrillation. We also see many of the beta blockers occur in these drug interactions, and it would be fairly common or expected that a patient that needs an antiarrhythmic drug would be on a beta blocker. Now, there are special considerations for the use of amiodarone and statins. The U.S. FDA released a statement restricting simvastatin specifically when used in combination with amiodarone. And this was due to a significant increase in the risk for rhabdomyolysis, kidney failure, and death. They recommend that the maximum dose used is 20 milligrams daily. We see that other statins are affected by this drug interaction as well. So simvastatin and lovastatin appear to be most affected by amiodarone, and atorvastatin seems to be less affected. Going back to this patient then, which of the following would be the most appropriate treatment recommendation for this patient? I believe that C, atorvastatin 10 milligrams daily would be the most appropriate treatment option for this patient. Now, we said that simvastatin 20 milligrams is the maximum dose that could be used in combination. That was option A. Now remember, this patient is on amiodarone 400 milligrams, which is a higher daily dose, and simvastatin 20 milligrams would be the maximum dose recommended. Since there are other treatment options available, it would be safer to consider one of the other treatment options than it would be to use the maximum recommended dose of simvastatin in a patient on a high daily dose of amiodarone. Now, because of what we discussed, 20 milligrams of simvastatin being the maximum dose, option B is no longer an option. And that leaves us with options C and D, which would be a starting atorvastatin. Atorvastatin 10 milligrams would be the most appropriate starting dose. At this dose, we would expect to see around 20 to 25% lowering of the patient's lipid profile, which is near our goal, and would most likely represent the safest treatment option as an initial starting dose. A dose of atorvastatin 80 milligrams would not be needed based on the degree of lipid lowering desired and would expose the patient to an increased risk of adverse drug events. Let's move on to some of the adverse events associated with the antiarrhythmic drugs, specifically QT prolongation. The resuscitation team has just successfully resuscitated a patient in room 307. The team reports that the initial rhythm displayed on the monitor was torsades. You are asked to determine if any medications in the patient's current regimen could have contributed to the cardiac arrest. A post-arrest electrocardiogram is available and reveals the following. Overall impression is sinus tachycardia with global ST segment depression. The patient's heart rate is 108 beats per minute, and the patient's QTC interval is 647 milliseconds. The patient's current medication history is as follows. The patient's home medication list consists of Dofetilide, lisinopril, metoprolol, hydrochlorothiazide, amitriptyline, and warfarin. When the patient was admitted to the hospital, the patient was continued on all of the home medications and then was also started on moxifloxacin, methylprednisolone, albuterol, ipratropium, and sodium chloride or normal saline infusion. So for this patient with a QTc of 647 milliseconds, which of the following medications most likely contributed to QTc prolongation resulting in torsades? A, amitriptyline, hydrochlorothiazide, and albuterol. B, moxifloxacin, ipratropium, and warfarin. C, amitriptyline, methylprednisolone, and metoprolol. Or D, dofetilide, amitriptyline, and moxifloxacin. I'll give you a few moments to consider your answer. QTc prolongation can occur in patients as a result of an adverse reaction to antiarrhythmic drugs and really many other drugs, as we'll see in just a moment. How this happens is that ventricular repolarization occurs during the QT interval. So essentially the ventricles relax, recharge, and prepare for the next beat. This period of time is referred to as the refractory period. If you increase the time of the QT interval, or you increase the time of this refractory period when the ventricles are relaxing and repolarizing for the next beat, it makes the ventricles vulnerable to arrhythmia, particularly to torsades. If you hear the stories of a baseball player that was struck by a baseball in the chest and had a cardiac arrest, it's most likely that if it was from the arrhythmia, that the baseball struck just during this refractory period when the ventricles are vulnerable. Now, we often use the QTc interval when we are looking for prolongation. We use the QTc interval because this is corrected for the patient's heart rate. Now, the normal QTc in males is 450 milliseconds, and a normal QTc in females is 440 milliseconds. Essentially, anything greater than 500 is considered prolonged and increases the patient's risk for ventricular arrhythmia. If we look at some of the risk factors for torsades, ventricular arrhythmia, we have patient-specific factors and some medication-related factors. Some patient-related factors are female gender, hypokalemia, hypomagnesemia, bradycardia, recent conversion of a different arrhythmia, heart failure, and then patients with a baseline QT prolongation, either genetically or because of medications they're taking. Some medication-related factors include rapid administration or rapid dose titration, an elevated medication concentration, either from failure to adjust the dose, for example, in patients with renal insufficiency, concomitant use of more than 2 medications that prolong the QT interval, and then drug-drug interactions. There are many medications associated with QT prolongation and this risk of ventricular arrhythmias, and specifically torsades. These are generally broken down into those drugs with a known risk, those drugs with a possible risk, and those drugs with a conditional risk. Now, what is interesting to note is when you look at the medications that can prolong the QT interval, it is not restricted to those medications that really only act on the heart, if you will. So, for example, it would make sense that the antiarrhythmic drugs would be associated with QT prolongation and potentially ventricular arrhythmias. But as we go through these lists, we see that there are several antibiotics that appear in the known list, so drugs that are known to prolong the QT interval, medications like azithromycin or ciprofloxacin. We also see that there are several antipsychotic drugs that are associated with prolonging the QT interval. Now, these lists are updated frequently and change frequently. So I would recommend that you consider either using your reference of choice or consider going to crediblemeds.org, which is what was formerly known as the torsades.org website, which is up to date in those drugs that prolong the QT interval. Now, if we look at Dofetilide, this patient was on Dofetilide as a home medication. Dofetilide has several unique drug interactions that must be considered. First, Dofetilide is metabolized via cytochrome P453A4 as minor metabolism, and then it's eliminated via the renal cation transport system. It first has drug interactions via the cytochrome P453A4 system. And the package insert states that inhibitors of this isoenzyme should be cautiously co-administered with Dofetilide. So examples being macrolide antibiotics, the azole antifungals, the protease inhibitors, SSRIs, and amiodarone. Concomitant use with other medications that prolong the QT interval also is not recommended, and this is due to the increased risk of QT prolongation for patients already on Dofetilide. So many examples here: phenothiazines, tricyclic antidepressants, macrolide antibiotics, the fluoroquinolones, essentially those drugs that we just discussed on the previous slide. Now, patients that are transitioning to Dofetilide from an alternative antiarrhythmic, either class 1 or class 3 drug, a washout period is required due to the significant increased risk in QT prolongation. Now, Dofetilide is contraindicated in combination with other renal cation transport inhibitors. This appears to be the most significant cause for concern of drug interaction with Dofetilide. The classic inhibitors that we think of are trimethoprim, ketoconazole, prochlorperazine, and cimetidine. It should also only be used in combination with extreme caution in patients also taking triamterene and metformin, for example. In addition, extreme caution should also be used when used in combination with potassium and magnesium wasting diuretics. This because of the risk that hypomagnesemia and hypokalemia pose in patients on Dofetilide, and the risk that those independently pose for exposing the patient to QT prolongation and torsades. And then the package insert also just states that Dofetilide should be used in caution with other cardiovascular drugs due to these drug interaction concerns. So if we look back to our patient, which of the following medications most likely contributed to QTc prolongation, resulting in torsades in this patient? The correct answer is D, Dofetilide, amitriptyline, and moxifloxacin. So as we look at the drugs that are known to prolong the QT interval, we know that Dofetilide should come to the top of our list because it is an antiarrhythmic drug. And then we also see amitriptyline and moxifloxacin appear on this list as well as drugs that can prolong the QTc interval. A safer treatment option for this patient would have been to switch to an alternative antibiotic therapy, specifically the moxifloxacin, to find an alternative to that to decrease the patient's risk of QTc prolongation, and perhaps obtaining a baseline baseline EKG prior to starting the therapy if no other options were available, with routine monitoring to ensure if QTc prolongation does occur, that changes can be made to the patient's therapy. Our final case today will be to discuss pharmacotherapy considerations in advanced cardiac life support. The resuscitation team is called to the bedside of a patient in cardiopulmonary arrest secondary to an acute myocardial infarction. The monitor displays ventricular fibrillation. The patient has received defibrillation ×3 and epinephrine 1 milligram ×2, but remains in ventricular fibrillation. Which of the following treatment recommendations is most appropriate for this patient at this time? A, administer amiodarone 150 milligrams IV. B, administer amiodarone 300 milligrams IV. C, administer lidocaine 1.5 milligrams per kilogram IV. Or D, administer magnesium sulfate 2 grams IV. The antiarrhythmic drugs are frequently used in the setting of resuscitation. Where they will be used are those patients that have ventricular fibrillation, ventricular tachycardia, supraventricular tachycardia, atrial fibrillation with a rapid ventricular response, and other tachyarrhythmias. So there's a diverse utility of the antiarrhythmic drugs in the resuscitation setting. If we look at pulseless cardiac arrest, as this patient is experiencing, amiodarone is considered the first-line antiarrhythmic drug for those patients in pulseless cardiac arrest that require antiarrhythmic drugs. So specifically, patients in ventricular fibrillation and pulseless ventricular tachycardia. The reason for this is that amiodarone has demonstrated improved rate of survival to hospital admission when compared to lidocaine and out-of-hospital arrest. Now, this time it's not thought to increase survival necessarily to discharge, but it does improve the rate of survival to hospital admission. Now, the recommended dose for amiodarone is dependent on whether or not the patient has a pulse. If the patient is experiencing pulseless cardiac arrest, so again, ventricular fibrillation or pulseless ventricular tachycardia, the recommended dose is 300 milligrams IV. If you're treating a patient with an arrhythmia that still has a pulse, so for example, atrial fibrillation with a rapid ventricular response, then the recommended dose is 150 milligrams IV. Lidocaine may be considered as an alternative to amiodarone. According to the current guidelines, only when amiodarone is available or administration via the endotracheal tube is needed. Now, these days with the readily available intraosseous access, it's not recommended that we use the endotracheal tube any longer for medication administration. However, if lidocaine does need to be given, then the first dose should be given as 1 to 1.5 milligrams per kilogram IV, and this may be repeated at 0.5 to 0.75 milligrams per kilogram IV, up to a maximum dose of 3 milligrams per kilogram IV. Magnesium can also be considered as an antiarrhythmic drug, specifically for those patients with torsades that have a prolonged QT interval. So looking back then at this patient, which of the following treatment recommendations is most appropriate for the patient at this time? I believe the correct answer is B, administer amiodarone 300 milligrams IV. Now, we said that for patients with pulseless cardiac arrest, the recommended dose is 300 milligrams IV. Therefore, option A is not correct. Amiodarone 150 milligrams IV should only be reserved for those arrhythmias that are being treated that still have a pulse. We said amiodarone is preferred over lidocaine, therefore option C would not be the preferred therapy. And then finally, this patient does not have torsades, and therefore magnesium sulfate would not be recommended. That leaves amiodarone 300 milligrams IV as a correct treatment option. Of note, if needed, this dose can be repeated if the patient remains pulseless after continued attempts at defibrillation and epinephrine 1 milligram every 3 to 5 minutes being given. If needed, amiodarone may be repeated at the second dose of 150 milligrams to a total dose of 450 milligrams IV in the setting of acute pulseless cardiac arrest. That concludes this presentation. Thank you for participating in this activity.